Welcome to the Indian Health Service's 70th Anniversary Tribal Summit. At this time, please rise and welcome the Surgeon General's Honor Guard for the posting of our colors. Guard, advance the colors. Honor Guard dismissed. Please remain standing for our invocation by respected elder from the Oglala Sioux tribe, Cecilia Fire Thunder.
Hamidakia Bilehina Giushki ma Belchis Papi. Na la Kolichetka Chajamitaki Matrochali we Majapi. Na Kiaksa Tioshpaya Mataha. Na le Lila Wanieta Otale Ahani Timawa Unashna Washi Echamu. Chanyukaleam Betukiwahi Wukhalila Yomakpi. Good morning. Greet you with warm handshake with good feelings from my heart. My name is Cecilia Fire Thunder, Oglala Sioux tribe. My Lakota name is Bear Who Climbs the Tree. I walked in this room and I saw so many people I worked with 100 years ago, right, girls? And I used to be in healthcare. And so it's such an honor to be with you today, and thank you for continuing to advocate for resources for our people back home. I'm deaf. I have cochlear implants, and so I have this little device that helps me a lot, okay? Many years ago, we had inner ear infections in our community, so we had no antibiotics. So many of us lost our hearing. So with modern day miracle, I hear more than I want to. Thank you. Tunga shilaya chea wa uwe. Tunga shilaya heya wa uwe. Mi takuye ob wanik de heya wa uwe yo. Hey, oi, Trunkashilaya, Trunkashilaya, hey, wa uweo, hey, Trunkashilon chima konjip tesowe, ma ele o homini wata ke ota, Na leo yana wichasha nagna jahipi. Na tukata ke wichozani. Oyate ki hena wa wa chiwi chuya pi chale abetu ki hena iwaglakakte. Na wiana wichasha ki dokya tahipi ki glana ish a hedgena. Wichozani oyate ki dokish ki iwashte pikta chapatita pikta chawapilat kanka hedja. Onshi wichala ye. Chante wika ki wichayut inzaye na isam wichakik suyaye. Na ha ish a dokish ke wachekiaki. Han wachekiaki. Daku chimpi na daku lapi ki washte pikte. O hedja domidaku yapi. Pilama yapi.
Thank you. You may be seated. Please welcome to the stage the IHS Deputy Director, Benjamin Smith.
Ben Smith. My name is Ben Smith. I'm a member citizen of the Navajo Nation, and I currently serve as the Deputy Director of the Indian Health Service. Good morning and welcome. It is truly a privilege to open this gathering as we mark 70 years of responsibility, relationships, and advancing health of our relatives throughout Indian country. Thank you to the Surgeon General's Honor Guard for their presentation. We are grateful for your participation in helping us begin today's summit with dignity and respect. And thank you, Cecilia, for getting us started in a good way with prayer. I want to begin by recognizing the tribal leaders, urban Indian organization leaders, former Indian Health Service directors, honored guests, dedicated staff, and tribal partners who are all here with us today in this room, as well as those who are joining us virtually online. Your presence here speaks to the strength of our shared commitment and the enduring partnership that sustains this work across generations. I also want to take a moment to recognize and sincerely thank everyone who has worked so hard to bring this event together. Events like this do not happen on their own, and we are deeply grateful for your efforts. As we mark 70 years of the Indian Health Service, I feel two things very clearly: pride in what has been accomplished, but also humility in knowing how much work remains. As we contemplate the beginning of the Indian Health Service, in 1955, Congress enacted the Transfer Act, establishing the Indian Health Service within the U.S. Public Health Service. That moment did not create the federal trust responsibility, but what it did do, it operationalized it in healthcare. 2 years later, the 1975 IHS Gold Book documented the reality facing our communities. What did we see? Tuberculosis filling hospital beds, inadequate sanitation, severe health disparities. When I read those early reports, what stands out is not just the hardships, but it's also the resilience, the insistence on partnership, and the refusal to accept neglect. This led to a huge turning point, and progress did not happen by accident. It happened because tribal leaders advocated, because clinicians chose to serve in remote places, because policy evolved. The Indian Sanitation Facilities Act meant safe water for facilities and communities. The Community Health Representative Program meant communities caring for their own people. The Indian Self-Determination and Education Assistance Act meant tribes leading their own health systems. Those were not just administrative changes, they were structural shifts. They reshaped Indian health. And that brings us to today, where we find that more than 65% of the Indian Health Service budget is administered by the tribes. This is reflective of 2.8 million American Indians and Alaska Native people throughout our system who are served across more than 600 facilities and 41 urban Indian organizations. We have seen measurable progress in diabetes outcomes. We have expanded cardiovascular initiatives to address heart disease. We have invested in sanitation infrastructure at historical levels. And for the first time, the system has received advance appropriation to stabilize funding. And that funding stability matters. It protects patients. It supports providers. It strengthens tribal health systems. As we contemplate what we have learned over time through leadership, and I'm pleased that this event is taking place in this great hall, because not only do we have all of the HHS secretaries looking down on us, we also see the partnership reflected in the Secretary's Tribal Advisory Committee member tribal flags in partnership. But what we've learned is that policy alone does not move systems forward. People do. Systems improve when federal leadership honors its commitments, tribal leaders step up and help shape implementation, providers are supported throughout our system, and most importantly, when communities are heard. I've seen firsthand what alignment between tribal and federal leadership can accomplish. I've also seen the pressures, and they're real: workforce shortages, infrastructure needs, persistent disparities. But sustaining progress is on the horizon, and we know that it is a call for transparency, consistency, and genuine partnership. As we look ahead, we are embracing priorities. First, to strengthen tribal self-governance, not only in authority, but in capacity and support. We're moving forward in modernization through infrastructure, health information technology, and workforce development. And with this, keeping at the center our relatives. Health is not only clinical, it is cultural, it is spiritual, and most importantly, it is intergenerational. The story of the Indian Health Service is not just a federal story. It's a tribal story, which means it is a shared story. 70 years ago, the foundation was laid. Today, the responsibility is shared. And tomorrow will depend on how well we listen, collaborate, and act. Anniversaries like this moment today are intended to celebrate, and we need to celebrate. But we also need to reflect. While we recognize progress and milestones, we also acknowledge the continued health challenges facing Native communities. The path ahead calls for sustained focus, partnership, and determination to improve access and outcomes across the system. Today is a time to honor those who built this foundation, and I see many of them sitting right in front of us today. Past leaders, but also the clinicians, the advocates, and community members, and to recognize those carrying the mission forward now. It is also a moment to be recommitted to the generations yet to come. Thank you for being here, for your leadership, and for your partnership. Let's begin this summit with gratitude for the journey behind us and determination for the work that is ahead of us. We are honored to serve during this chapter of the Indian Health Service story, and we are grateful to walk this journey alongside each of you. Thank you.
Please welcome to the stage IHS Chief of Staff Clayton Fulton.
Good morning. I appreciate you all being here. I see many tribal leaders that I have had the pleasure of being with this week. I see leaders from our other federal partners. I see so many faces that make this happen every day. It's not a one-man initiative. It is a team effort, and many of you have been carrying that torch for many years, and I applaud you. So, as you know, we gather here today to reflect on 7 decades of fulfilling the sacred trust responsibility to raise the physical, social, spiritual, and mental well-being of our communities. And this is a celebration both as a reminder of that commitment and a chance for us to take a moment to look with respectful gratitude back to what has brought us here and unite in the unity of hope of the things that we will achieve moving forward. When we look at here, I want to take a special moment to thank you for the work you do in your communities, at IHS, in your various roles at federal agencies across this government that support the work we do. But I also want to take a special moment to thank Secretary Kennedy and the efforts that he has put in his first years leading here at IHS, or at the Health and Human Services, and the special focus he has put on Indian country at all levels. Because Indian health is more than just what happens at the Indian Health Service. There are efforts being made across here, and those efforts, largely spearheaded in part by Mr. Cruz over there, and under the Secretary's leadership, have been immense. He has visited Indian country more times than I think any secretary in his position has to date in their first year. And so that commitment is essential. And he will be here later today to present some of that on his own and share about his passion for Indian health. But I'll tell you, it does make a difference. It makes my life a lot easier when we're in line and doing the good work together. So, needless to say, as we remark on 70 years of IHS operations, we remember that this is not a story that just began 70 years ago. It's one that's much more ancient, that's been ongoing for centuries. It starts in the early treaty days, in which many of lands and peoples exchange for the promise of being taken care of a trust responsibility, and many times of health care directly, knowing how essential it was for their people, for their communities, and ultimately for the future that we get to share in today. That sacred government-to-government relationship shapes everything we do here at the Indian Health Service. But we did see some unique landmarks as we move through time. Specifically, we look at 1849, where we first see that Indian affairs and Indian health transfers from being a military activity to one led by civilian control. But it's not until the 20th century, in 1911, that we first see actual appropriations made by Congress that demonstrate a dedicated commitment, setting aside specific dollars, not just part of a different program, but a direct intent to say Indian health matters and deserves its own line item. We roll forward to the day that we're celebrating today, in 1955, when Indian Health Service was created by transferring the activities and functions out of the Department of Interior over to the predecessors of HHS as we know it, and moving it into its current form as a dedicated, standalone agency, which was still an evolution, but focused specifically on providing care in our communities and fulfilling that sacred trust responsibility. And the work continues. Each one of those shows a small step in the evolution that has improved the lives of our communities. And that evolution continues. Whether we look at the extraordinary growth, modernization, and transformation of how healthcare is delivered. I will say, we've got one other big deadline that I've missed. The Indian Self-Determination Educational Assistance Act, which took place just over 50 years ago and revolutionized it again. We went from a system just dominated only by federal control to ones in which tribes were able to take over and engage and bring the care directly to their communities and be involved in the day-to-day decision-making that makes that happen. And boy, has it been a resounding success. We've seen immense growth, evolution. We've seen people tackle things that had never previously been dreamed of in the history of the agency. And that has been a wonderful thing for us to get to involve. Each one of those steps left a legacy of lives at clinics, prevention programs, community health initiatives, and a legacy of care and compassion. At the same time, while we're honest and looking at the retrospect of how we got here, this is not the end of the work. This is merely the beginning of the same steps. In the same way that we have evolved over the last 2.5 centuries, in the way we approach Indian health, we will have to continue to evolve. The challenges are still immense. There are more people in need of care today than we've had ever before. And what an amazing challenge to have before us. We're going to have to tackle this in new ways, but ultimately they have to be built around deeper partnerships and a stronger shared commitment to the people, the relatives we serve. And so, on this moment, I'll take my opportunity to share with you my commitment and to ask you to join me as we look at grounded ways that tribes, tribal organizations, our urban partners, and we here at the federal government can work together to achieve what we have yet to accomplish. As we look at how do we grow our workforce and get more people into the field and delivering care and building relationships, not just people who are passing through, but people who are deeply committed to the individuals that come through our clinics. How do we improve facilities and build the infrastructure that was never built in Indian country that is necessary for us to achieve and succeed at the levels that we need? To look through and say, how do we use data in modern and accessible ways that are still culturally aware of our needs, but unlock new insights and information to achieve greater health disparities and achieve ultimately longer lifespans. We look at each one of these as unique challenges in the part of the evolution, but the greatest challenges are the ones we are yet to know. We know that there will be new opportunities before us that we are going to have to seize. But no matter what those are, no matter where we go, it's essential that we go together. One of my favorite sayings that a mentor of mine gave was, if you want to go fast, go alone, but if you want to go far, go together. And that is where we're at today. So on this anniversary, that is my call to action, is that we recommit ourselves today to partnering, to working, to solving the challenges, so that this system can endure, that your systems can succeed, and that we can collectively and together carry forward the torch that so many generations before us have carried. So with that, I appreciate you being here. I look forward to getting to mingle with you throughout the day, and I hope that you find this moment as invigorating and fulfilling as I do. Thank you.
All right, please welcome to the stage our moderator, Principal Advisor for Tribal Affairs, Devin Delro.
Hello. All right, it's working. Great. Well, good morning, everyone. It's so nice to see all of you. I love the job that I have because I know so many of you tribal leaders, tribal representatives, and it's always good to come together at events like these. So really happy to be here. As was mentioned, my name is Devin Delro. I serve as Principal Advisor for Tribal Affairs here at HHS, also a citizen of the Navajo Nation. I'm joined today by some esteemed colleagues and friends. Dr. Loretta Christensen, Chief Medical Officer at the Indian Health Service, A.C. Locklear, who serves as Chief Executive Officer at National Indian Health Board, and hopefully, I know Dr. Yvette Rubidoux is running a little bit late, stuck in D.C. traffic, you know how that goes, so if she's able to join, she'll join us on stage here. But it's my honor to moderate today's first panel discussion focusing on physical health, which is that part of the IHS mission statement that's focused on prevention, wellness, and culturally informed care. I'm going to ask a series of questions to our panelists and hopefully generate some lively discussion. So with that, let's go ahead and get started with our first question. So we'll start with you, Dr. Loretta Christensen. Drawing on your experience across the Indian health system, what approaches have proven most effective in promoting prevention, wellness, and culturally informed care within tribal communities?
Yes, thank you for that question. And there's many answers to this, but some really great things that have happened include something very recent where my staff, in combination with our other colleagues across the agency, did a GONA for the construction of a new hospital in White River, Arizona. They spent time with the community, walking through all their needs, giving them input. It was a fabulous experience for both. And we hope to replicate this as we move on to new facilities, but it was a total engagement of the community. It is their hospital, it is their gathering place, and we tried to optimize everything that they wanted in those plans, and it's going to be beautiful, by the way. So great work with that. We have managed, the JMI program started way long before me. We tried to resuscitate it, if you will, and there's still some areas, particularly the Navajo area, that does a full event every year, every summer, every week, and they have so many hundreds of people that show up. It's like they look forward to it, and it's all for the community. We get the opportunity to screen, teach. We have contests for the young people to learn about healthy eating, better exercise, and it really allows our staff to engage fully with the community in a way that they're happy and doing something they love to do. And I hope that continues, and I hope it respreads across the agency. There's many examples of our healthcare facilities that engage communities for joint events. It is tribal leaders, tribal members, our staff, and these are very successful. We're able to talk to each other, we're able to learn. Everybody's bringing their experience to these events, and they've gone so well. We hope to continue doing that and increasing that engagement across the agency. Other ways that we look at customs are even in the way that we give birth. We look at what the tribal customs are, and as much as possible, we integrate this into our processes so that they are comfortable with those births and whatever customs and traditions their tribe has for those babies so that they start in a good way. And we accommodate as much as we can within our facilities, working with people from the tribal communities. And then my last thing I want to mention is I'm very focused on converting our very austere government buildings and hospitals to more welcoming places. And we want to really work on how we integrate the tribes in our facilities. And I'm going to give the credit to the tribal leader who told me this needs to be a place of healing. And I heard him very loud and clear. So we're now not saying we're going to go to IHS, white walls, uncomfortable chairs, things like that. We're saying put the art up, put the customs of those tribes in the hallways, make them feel welcome, make them feel safe here. And we're really doing a big conversion here to become just places of healing where people can come for that respite, for that care, and be comfortable in that environment, which goes along with our work on trauma-informed care, which, as you know, it is mandatory for our staff, but it's a bigger passion than that. It's also creating a trauma-informed environment for people to come and to be cared for. So those are a few things that I think are very important in integrating the tribal customs and people into the work that we do for them, which we do for them. Thank you.
Great. Thank you, Dr. Christensen. AC, same question.
Yeah, definitely. I think from our perspective in the National Indian Health Board and working with tribal leaders across the country, one of the things that we hear a lot is that one of the most important lessons in prevention doesn't really start in the clinic. We really want to start thinking outside of just traditional direct care and how we're providing that to our community. It starts in the community. It starts in the relationships. We see that it's ingrained in our community. Public health as we know it is something that tribes have been practicing in some capacity for pretty much their entire existence. How they ate, their cultural practices, ceremonies, and it's checking in on elders, checking in on their community. It's something that is ingrained and innate, and how we incorporate that in our care is important. So today, the programs that really demonstrate that are the ones that really reconnect health to those systems and those practices. And one example I think of a lot is community health workers and representatives going into an elder's home. They're able to really see a lot when they visit their community members. They're able to see how they're eating, what medicines they're taking. They're able to find and determine things before they become a problem or an issue. And they're able to really address that ahead of time. So before care is needed in an IHS facility or in a clinic, they're able to address a lot of those on the forefront. SDPI is another huge example of that. When tribes and tribal communities are given control to be able to initiate programs to really address things like diabetes prevention in a way that really works for their community, we see how successful that has been for decades. And it's something we really want to make sure that we're continuing. So we consistently see when tribes have the ability to influence, to work with IHS directly on how their systems and integrating culture into their facilities. But it goes a little bit beyond that, right? It's not just about, art being on the wall in a facility or language being in the facility. It's really about that direct, consistent engagement outside of that direct care that is really important, that we see that it has the biggest influence.
Great. Thank you for those answers. And, I was thinking about how Dr. C mentioned that seeing the culture in the in the walls of the facilities. I can't help but, mention the fact that we have flags of our tribal nations here on the walls, and that's so important. For me, for other colleagues to see that every day when we come into this building reminds us of our nation-to-nation relationship, our government-to-government relationship. So that, that practice, I think, carries forward, not just at the, clinic, hospital level, but, of course, other federal buildings. So thank you for that. Second question, what practical lessons from your work could be applied more broadly across IHS, tribal, and urban settings to improve everyday access to care?
Okay, this is a great topic. You know, in the heat of the pandemic, we learned a lot and on the run, but it stuck and it worked, and we made it work. So some of that is very important to carry forward, and one of the main things that was learned from that is you take the care to where the people are. And I know that we don't get a large percentage of people that get to our facilities, either because they can't get there, they feel like they're okay, or they just don't seek care. So what do we do with the other part of the population that needs prevention? We have to go to them. And so we have some very unique programs that I hope are going to replicate across the agency, where a prevention team actually goes to the community. They do screenings. They do follow-up after discharges. They do an amazing job. And this started during the pandemic, and it has carried forward. And would love to have that everywhere, because we know transportation is a problem. We know people can't get to appointments. And I don't want to get them later to come in when they're really ill. Let's get them when they're healthy and keep them healthy. And that would vastly decrease chronic disease management if we're catching things very, very acutely. So we want to replicate that. We have put other programs out in the field. You know, we've all suffered with the STI outbreaks across Indian country, and we've addressed that by going out to the communities, going to places people go, and catching them where we can catch them, and making sure they're screened and treated properly. And we were one of the first in the country credited with going out there with our public health nurses, testing, treating right there, looking for the contacts right there, contacts, and treating them. And this still goes on, and I think that's why we are finally seeing the decrease in rates. We're not there yet, but we've made great progress with this full-on deployment out into the communities. And so this has worked very well, and I think it's very, very important that we continue this. We also have really employed a tremendous amount of community-based messaging. It's fine to see it on something, but does it mean something to you? I think we have to transmit that in a way our community members understand. And I'm going to give you a couple examples that are really important. How do you know you're sick? Well, we say, well, you're going to sneeze, you're going to cough, things like that. But there's other more insidious disease that I don't think people are aware till they're very, very ill. So we have done a lot of work on that. How do we get out with that prevention? I'll give a shout out to Dr. Clark, who for the first time in 25 years redid the PRC. And as many of you know, it's equal. Prevention and rehab is equal to medical and dental, to maternal child health and behavioral health. They're all that important. They're all part of the same person. It is our mission, that holistic mission, that we need to be able to provide care in all of those things. And it has gone very well. People are getting screened. They're getting more prevention examinations. And one big project we hope to roll out this year is to go out and do those annual wellness exams that people don't get. This is where we pick up blood sugar issues, early hypertension, so we can intervene. Then they don't stay ill, they stay healthy for a longer time. But we'll go to them. It's okay. We need to go to them if we can't get them in to see us. And make that the standard, that this is what you should do every year. You should get checked every year. One of the last things I'll mention that I think is very, very important is we also have self-monitoring blood pressure, over 1,000 out in the agency right now, and we continue to add them. So we not only deliver them, we send our public health aides and staff out to teach them how to use it, when to contact somebody, when they should be worried about the numbers on there, making sure they're putting the cuffs on right, etc. So that is a huge push. It's for monitoring during pregnancy to pick up on problems very early, and of course for cardiovascular management in patients so that they don't get severe sequelae of having prolonged and long-time blood pressure issues. So that's the type of things that we really are focused on, is that we need to get it before it happens. We need to get it out there. And a lot of our work is being done that way. And of course, we consult with our tribal partners. We look at the people, what's the best way to say this? How do we express this in a way that is perceived and understood? And I I think that's the future for us, is to be out there in the field with the people we serve. You know, I'm very encouraged by the progress we've made so far on this type of work. Thanks.
Great, thank you. You can clap, it's okay. AC?
Yeah, Dr. Christensen.
Oh, 1 second. I just want to mention we are joined by Dr. Yvette Rubidoux, former IHS director. Thank you so much for being here. I know you got caught in traffic, so we're so happy to have you here. And we'll continue with AC, and then I'll repeat the question for Dr. Rubidoux.
Yeah, absolutely. You know, Dr. Christensen couldn't said it best, and those examples of what IHS is doing is exactly right. It's really about changing the system to really meet people where they're at. You know, she mentioned long distances. She mentioned things like work schedules may not match clinic hours. We're talking about intergenerational homes. And a lot of times we're seeing, especially with the workforce shortages, you know, our communities are going to clinics and not recognizing anyone there because their providers aren't there long enough for them to develop a relationship, which that builds trust and gets people into things like those annual exams. So when we expect patients to mold themselves for the system, then that's where we lose trust. And these programs, like Dr. Christensen said, is really about building that trust and making the system fit the patients and our clinic's needs. So we've seen that, like she said, during COVID, with telehealth is a huge one. We've been able to see that dramatically increase access to care across the board. School-based clinics, mobile units, home visits, all are different approaches that have had huge impacts in Indian country. Another important lesson is something that we see from our urban Indian organizations. You know, many of these clinics all provide similar or the same services as many community-based clinics: primary care, screenings, behavioral health. But Native patients continue to use them more consistently, and it's because, you know, the medicine doesn't change, but the relationships that they build with those clinics do. You know, they feel that they see themselves and they understand themselves there, which is something that is a very interesting kind of dynamic when you think about the access to care piece. They could get it somewhere else, especially in urban areas, but they consistently go to those clinics. So a culturally familiar environment builds trust, and it's really about designing those systems differently to meet the patients.
All right, thank you. And Dr. Rubidoux, the question was, what practical lessons from your work could be applied more broadly across IHS, tribal, and urban settings to improve everyday access to care?
Thank you. Well, good morning, everybody. I am so sorry to be late. The traffic was horrible, and I think I haven't driven to D.C. in about 4 years, so I was a rookie today. Well, again, I'm Dr. Yvette Rubidoux. I'm a member of the Rosebud Sioux tribe. I am also descended from the Standing Rock Sioux tribe, and it's great to see you all today. Thank you to all the care providers and the tribal leaders that we have here today. Thank you so much for your care and your advocacy for all of us. We really appreciate it, and I'm really glad you're here today. So, practical lessons that can be broadly applied for access to care. Well, we all know that access to care has always been an issue, but I really do think it has gotten better. With regard to access to care, I really like seeing the trend towards team-based care in the Indian health system, in IHS tribal and urban Indian health programs. By centering care for patients with a team of providers at the right time to meet their needs and the care they need on that day has really proven itself to work. I mean, I even have to say that I see my family members getting in quicker than I used to get into back in the 1970s. I was thinking last night, you know those colored plastic chairs we used to have to sit on in the waiting room back in the 1970s and 80s? Well, it's a lot better than that now in a lot of facilities, and so that's really great progress. So working in the Indian health system is a team approach, so it makes sense that that could help improve access to care. I also think that we must mention one of IHS's biggest achievements, which is trying to create more access to care through the getting more providers through the Indian Health Service Scholarship Program and the Indian Health Service Loan Repayment Program. You actually may know that I was the first IHS scholarship recipient to eventually become the IHS director, so there's an outcome for the system. But these programs, as you know, support healthcare providers to work in the Indian health system and help pay for their educational expenses and help pay back their loans. And I think I remember seeing data that said that providers who come in under these programs tend to stay a few years longer than others. So it really does help access to care. So a way to improve access to care is really related to the getting more providers. And the IHS Scholarship Program and the Loan Repayment Program are really important. And they deserve some recognition and more resources so that we can have more providers come work in our communities. This brings up, of course, the lack of resources, funding, and providers. And that's all still a significant barrier to access to care in many places in the Indian health system. There continues to be a need for more competitive salaries for providers, appropriations for new facilities, better orientation and education on how patients can effectively access the system, and time to actually work on these improvements. These are all necessary and needed strategies to continue to improve access to care.
Thank you, Dr. Rubidoux. We've come a long way, but we still have more ways to go, so thank you for that. Our next question, how do successful care models balance clinical best practices with community knowledge, culture, and local priorities?
Yes, thank you for that question. In the IHS, we have put forth in the last 4 years or so multiple strategic initiatives. And the way we decide what we're focusing on is we look at the impact of each one of these disease processes that impacts our people the most. We started with our E3, which was during the time of the pandemic, which was every visit, every vaccine as appropriate. Every visit we were supposed to look at that and make sure everybody was covered. So that is still there, and that started out our strategic initiatives. We went to ACT, asthma control in tribal communities, when we saw how many children and families were affected by asthma, and to the point that our colleagues in environmental health started doing pilots of going into homes and teaching the families what was provoking the asthma. They would help them clean it up, put filters, show them ways to make that environment less provocative to the kids having an asthma attack. And we're going to expand that, so because we can't just give medicine, give inhalers. We actually have to look at the environment that is causing the problem. So that was our second initiative. And then we went to native hearts, because we know cardiovascular disease is the #1 reason for mortality in men and second for women. And we know this is a big problem we have in relationship to the high rate of diabetes as well. So now we're breaking down the different parts of heart health and addressing each one of them in a way that is impacted into the community. And then I'm going to tell you the fourth one that we just launched, which we're very focused on right now, is liver disease. And it's all forms of liver disease. That is the 5th leading cause of mortality in Indian country, and certainly for IHS. So this is when I said, how do you know you're sick? This kind of brought forth that we have a lot of work to do on this, So we actually started our first community of practice with the doctors for liver disease. It is driven by clinicians. It is giving them a chance to speak to each other, best practices, share protocols, and develop that work for the patients that we serve. But the other part of that is my public health council does messaging into the community saying, if you have this, if you see this, come in. Because we're getting people in too late for things like when they need a liver transplant, they're too late. So, but we can't see everybody. We depend, and we love our CHRs, our community health representatives. We have some public health aides out now as well helping. Our PHNs, you don't find those anywhere in the country. This is an amazing program that we have at IHS. And they're the ones that go out and make the contact. So we're doing navigation training. We're telling them how to go out and go over these symptoms with people. If any of these symptoms come, we're getting you in. We're going to diagnose you early. We're going to get you stabilized, and we're going to not let that progress to fatal liver failure. And so this is our big strategic initiative right now. This will go on for a while because we're addressing hep C, viral, and metabolic causes, as well as hepatocellular carcinoma. So it will be in phases, and then our one after that will work on kidney disease. So we're looking across our population, what can we most educate about? How do we get it into the communities? And when we ask our elders and the people in the communities, how should we talk about this? How is the best way? A very recent program we're very proud of is our Alzheimer Dementia Project. It has gone into the it is the community. This is how they set it up. This isn't us telling you this is Alzheimer's and dementia. It's the community recognizing that there are these symptoms or these subtle things going on. And so it has done a fabulous job of education, of engaging community, training providers to do the right questions, because believe it or not, some of my best providers said, I took the geriatric course that they offered, and I didn't know what I didn't know. I feel like I do such a better job now. So we're actually even hitting the providers, nurses, and the teams that have been referred to that take care of the patients. So these are the way we take these initiatives, and we apply them into the community, we engage the community, and we have them help us really navigate. Another very excellent program is our community-based colorectal cancer screening, which will be extended to, as the new science comes out for cervical cancer, self-testing and such, we are prepared to roll those out because we get it back. They like to do privacy, they like to do it themselves. We guide, we do instructions, we call and follow up. Did you send it back in yet? Do you want us to pick it up? And this has vastly increased cancer screening. So this is the way to do it. It's to go out there, talk, teach, answer questions, and help them get through all of the steps of this. So thank you.
Love that. Thank you. AC, next.
Yeah, definitely. I think just echoing off Dr. Christensen, the best models are the ones that we have the clinical care, the clinical science, and the traditional and community knowledge that are really complementary. They're not treated as separate, or they're not treated as kind of adverse to each other, but they're treated together. So we think for, diabetes management plans. Adherence really depends, and we see in studies that it depends on the family's involvement. It incorporates traditional foods. It connects to daily routines with the household. We see that through SDPI and how tribes and communities are able to create different programs to address these issues based on their community. So we kind of see that model really play out there. We see it the same in behavioral health. Counseling is important, but outcomes really improve when it's paired with cultural connection, community support, family involvement in that practice. We see those improve dramatically. Integrated care models. I know Dr. Rubido talked about team models, but those integrated care models where at that point where a patient can be seen by behavioral health experts, by their clinicians, their primary care physicians, nutritionists, all at the same time, in addition to a traditional healer if they so choose. And it really allows, greater access. It really allows, it's really one of the best practices that we see out in Indian country. And it is something that is expanding beyond Indian country. We see that really holistic model being used in a lot of Western facilities and it's being really championed in a lot of, commercial hospitals across the country. And it's something that Indian country has really been championing for years. So it really is about a balance. And I think today's theme and IHS's mission is really essential to that. It's about the mental, behavioral, physical well-being and seeing it as all within that model at the same time.
Great, thank you. Dr. Rubido?
Thank you. Well, I really love this question because I think the very best model of balancing clinical best practices and community knowledge, culture, and local priorities is the Special Diabetes Program for Indians. The example I have is experience that best illustrates that the SDPI diabetes and healthy heart prevention demonstration projects is a great model for how to combine the clinical practices with community knowledge, culture, and local priorities. So these demonstration projects were funded starting in 2004 for $27.4 million a year. And this was an initiative within SDPI to translate the research that we knew showed that diabetes can be prevented and so can heart disease. These grants were given to a very diverse group of 66 IHS tribal and urban Indian health programs. The focus again was diabetes prevention and heart disease prevention. I really remember how excited people were when this new initiative was funded for 2004. I was grateful to serve as the co-director of the coordinating center, and the director of the coordinating center was Dr. Spiro Manson, one of my mentors. I remember people getting really excited and suggesting all these national experts that they could bring in to come teach the science and come tell the programs and the grantees how to do this. Well, I was really grateful that Dr. Spiro Manson strongly insisted that the grantees from the communities were the experts, and that this could be developed with peer-to-peer learning, with the communities leading the effort. Well, after much discussion, finally we were able to proceed with this collaborative, team-based approach, and only a couple of experts were invited to speak, but the entire initiative was basically designed, implemented, and evaluated by the staff from these IHS tribal and urban Indian health programs. They worked very hard. And the grantee staff, for example, developed the core elements based on the research that we were translating on prevention. They developed and implemented an evaluation that showed that their prevention activities achieved similar outcomes to the research that we were actually translating. They showed that a community could lead and achieve amazing outcomes. So I believed then, and I still do now, that the only way that we are going to improve the health of our communities is to partner with them and let these communities take the lead. Healthcare systems within IHS and throughout the country really must learn to partner with the communities they serve. And I believe with SDPI, the IHS tribal and urban Indian health communities have really been a model for diabetes prevention and heart disease prevention. And this is a model not only for Indian country, but for the nation and even maybe the world. And so we must partner with communities, and that helps us combine the clinical approach with community-led solutions. So that's my example of this, is the SDPI.
Great, thank you. So you all mentioned several successful models, but I'm wondering what partnerships or what other partnerships or coordination efforts have made the greatest difference in sustaining prevention and wellness efforts over time? Are there others that you would like to mention? I'll start with you, Dr. C.
Well, I think everything is about partnerships. Even in an exam room, you're a partner to the person that you're serving at that time, your full attention. For us, it's always not only the patient, but the relatives and the family. And this is a big goal as well. How do you bring the family into that care? Because we know someone may be translating, some may be driving that person to appointments, and they have to be fully integrated into your plan. So that's something that we need to be better with, is making sure those families are engaged as well. So that partnership starts that. Then we go to the ones that have been well spoken about, and SDPI is the greatest example of all across Indian country doing the same type of work with their own custom, with their own approaches to it, yet that has had the best results of anything we've done in IHS, like tremendously. We have that as a goal, and everything we do is that we can get together and share across everywhere. And I think I've said to many of you, I believe everybody's our patient. It doesn't matter if it's urban or it does tribal or it's IHS. We're all patients together. We're all people together. So if you're not engaging everybody in these initiatives, in the grant opportunities, in funding opportunities, we're not getting that balance that we need to be a holistic approach to care in Indian country. So I think that partnership is invaluable. And then we do have to look at partnerships external to Indian country at times, because sometimes they bring something to us in technology or work that can help us do our work better. And I certainly don't want to leave out our other partners within HHS. We've worked very well. It's kind of changed a little bit, but we still know each other. We still call each other. We still work through things, and we all help each other with things that we know best, that they might need, and they tell us things they know best that we need. So I appreciate those partnerships with SAMHSA, with CDC, all of our colleagues, ARC, everybody there. We all are one team, and I think we've done some amazing work together. So I think there's many, many partnerships, and you just have to find the right combination for the project that you're doing to make it the best outcome that you can. And so I think we'll continue to mature with those models and really have just this great input from everywhere that we need to do our best job.
Great, thank you. AC?
Yeah, definitely. And just to kind of quickly build off that, we've seen the greatest successes across the board when IHS, urban facilities, and tribal facilities work alongside states and other partners to really advance, whether it's during COVID and public health prevention, whether it's workforce development. We consistently see those partners as integral to having any success in Indian country. I think one of the things that I'm excited to see is a continued relationship with IHS and the VA, and what that really looks like and how that impacts our veterans, our Native veterans in the future, their access to care. I think it has the potential to really benefit both those and other veterans across the United States. I look forward to and continue to look at some of the partnerships across HHS, whether it's with SAMHSA and IHS, whether it's with CMS, when they're all around that main goal of improving tribal communities. We see them work together to solve some of the biggest problems. That constant communication between IHS, CMS, and tribes is one of the most functional relationships that we have in advancing tribal priorities, because it's so critical to what we do. So those are some of the most sustainable investments. I know that we've talked a lot about other examples, but I'll give Dr. Rubidoux an opportunity to answer.
Thank you. Well, this is a celebration, so I'm going to talk about a little history. And again, I'd like to talk about the SDPI. But first, I want to recognize the great tribal leader, Andy Joseph. I think that's you back there. Stand up and say hello. He is one of our champions of the Special Diabetes Program for Indians. And if there's others, I can't see, but I saw you back there and I thought, hello, this is one of our champions for community, tribally driven healthcare, and especially for diabetes. So thank you very much. Well, again, now some history to talk about how partnerships can make the greatest difference in sustaining prevention and wellness efforts over time. So the history, way back in 1997, I know some of you weren't alive, but for those of you who were, the Balanced Budget Act was passed, and that's what authorized the Special Diabetes Program for Indians. Everybody was so excited, I remember, and seeing that funding, it seemed so big, $30 million a year. Well, now it's $200 million a year. Great job, HHS and Congress. Well, back then, IHS Director Dr. Trujillo convened a group of tribal leaders from each IHS area and added 4 diabetes experts, and I was a part of that little group. So over a 2-day meeting, we were tasked with developing the method to distribute the new SDPI funding. It was so exciting, but actually it was a really tense meeting. Every IHS area and every tribal leader present appropriately felt their areas and communities deserved a greater share of the funding. So the meeting discussions at times were intense. Voices were raised. Actually, I was a little scared. I have to admit that was my first tribal work group experience. But in the end, it all worked out as it usually does. And the tribal leaders themselves developed the basic funding formula for the special diabetes program for Indians. And that has served the test of time. And it's been almost 30 years. And SDPI, as we've said, is one of the most successful medical, public health, and community-led initiatives in the country. And it has amazing outcomes related to the prevention and treatment of diabetes in American Indians and Alaska Natives. So by partnering with community, even when it might be challenging, this allows community to determine how to best serve the needs of their communities. The Indian health system has made significant progress, and this approach is really the only way we will return our communities to health and wellness by partnering with our tribal nations. Having come this far in this partnership towards the health of our communities that we serve, that the IHS serves, certainly is worth celebrating today.
Great. Well, thank you so much for that history lesson. So we do have a little bit of time, so I want to make sure that our panelists have a chance to provide any comments about other areas that we haven't talked about yet. Any closing comments, thoughts, reflections on your time at IHS and reflecting on 70 years that you'd like to share with the group?
Well, I haven't been here the whole 70 years, but it is a complete honor to work for the Indian Health Service and to serve the people that we're to care for. And I think that I've been blessed with a staff that is amazing, dedicated, compassionate, and they work with love, really. We get through so many things that way that I can count on them for anything. And we just keep advancing. We are doing some amazing data analytics right now. We're really getting down to where we can look at the bedside. Is the care what we want it to be? And we take that time then to work with the providers and say, this is how you did this. We think it could be better, and then give the guidance. We're developing protocols across the agency, and we're able to watch them even in our legacy, very old RPMS system. I have brilliant programmers that are able to pull the data now, and we're able to actually see if you took the blood pressure, if you looked at this, when you started a treatment. And we really feel that is the thing, the last key to making sure that care is as best as it can be. All providers are trained differently, and I mean all levels of providers. So how do you get them on the same page? How do you show them that we're 2 to 3 times more vulnerable to most all disease processes? How do you say to them, you have to be prescient and you have to go after things early so we catch these and able to treat it? You give them data back. People want to see how they're doing. They may not want you to say it in front of everybody, but they do want to know that they're doing a good job. Nobody does not want to do a good job for the patients we serve. So this is a next step for us. Then on the other hand of balance is balancing that cultural appropriateness and humility. And I would be remiss if I didn't mention traditional healing today, because I see my favorite cousin here, my relative, is going to talk about how that works in a blended and full team, which I am both envious and awed by. But we work so hard, all of us, to get this over the finish line. And we are still meeting with Medicaid to extend it to more than the 4 waivered states. And so we're really working on those things right now for all of Indian country. But this was the missing step there, is that spiritual component wasn't there. So I think we all did a beautiful job with that. I look forward to each program developing and learning from each other. And that person will be integrated fully, our healers, into what we do every day, because our patients then see we respect that spirituality and belief, and we've integrated it into our entire system where it should have been. So I just wanted to get that in because this was a labor of love, and there's some fantastic work going on you're probably going to hear about. And thanks to everybody that supported this and worked so hard. So we have a balance. We have the traditional medicine man or healer, and we have our wildly wonderful data analytic analysis and things going on, so that we are balancing new technology with who we are and where we came from. So that's how I would like to end that, is that's the most holistic way to treat people that I can think of at this time. So thank you.
Love that connection to balance. Really appreciate it. AC?
Yeah, definitely. I think something that I want to take a moment and just kind of center ourselves on is, often as advocates, we're in a position where we're coming to IHS with all the issues, right? We're always really advocating for the interest of tribes, but sometimes it can feel a little bit adversarial. But in reality, our relationship with IHS is that of partners. And as the 70th year of IHS and celebrating that, I think we don't really reflect how many warriors there are across Indian Health who are fighting day in and day out to make sure that our people are cared for. Dr. Christensen talked about so many new programs that IHS is doing to try to improve the health of our communities, to listen to our communities, and in doing so with so little resources, with so few people. It's just something that should be applauded day in and day out, and you see how much they care about our communities. And that's something that, we often have to center and think about, because when we're trying to continually fight to improve the well-being of our communities, sometimes that gets lost. And it's something that, I really try to instill in our staff and in travel leaders when I'm talking, is to really elevate and think and just appreciate all the work that is being done. And I think, just lastly, is something that, I think has been weaved into this conversation and just hasn't really been stated, is just, Indian Health really works best when it's done alongside tribal nations and tribal people, whether that's influencing how IHS is delivering services in their community, whether that is controlling and directing and, creating those services. It really has shown us time and time again that is where Indian Health should be. So that's something that we should really continue and think about, and how to build upon that in future years.
Great. Thank you. Dr. Rubidoux, closing thoughts, the last word?
All right, thank you. I just realized there's tribal flags in this hall, and it wasn't that way 10 years ago. And I think that's a great achievement for both IHS and HHS. Tribal self-determination and self-governance has been a critical component of the progress of the Indian Health Service and the Indian health system over the last 70 years. I remember when I was a very young clinician. I was like, 70's pretty close to me. I'm like, wait a minute. But when I was a young clinician practicing back in the Gila River Indian community, way back in the early 1990s, I saw the amazing quality of care that was being delivered by the IHS program. And then I saw the tribe take over the management of that amazing IHS program under 638, under self-governance, or self-determination and self-governance at that time. And it's just amazing to see over the ensuing, 30 years, that the Gila River Indian community has an amazing healthcare system. The Indian Health Service is an amazing healthcare system. Tribal health programs are amazing programs. And urban Indian health programs, as underfunded as they are, we still recognize them as amazing health programs doing the best they can in urban Indian settings where there's no other option for them. So there's a lot to be proud of. It's 70 years of the Indian health system. And I find myself saying Indian health system more and more as I teach people about American Indian Alaska Native health, because it really is truly a partnership of IHS Tribal and Urban Indian Health. And there is a lot more to do, but we can really be proud of the progress made over the last 70 years, and let's make sure we continue to make that progress in the next 70 years.
Thank you for that. Please give a round of applause to our panelists. Thank you.
Coming to the stage for our second panel for mental health, please welcome the moderator, director for the Office of Tribal Affairs and Policy, SAMHSA, Karen Hurd.
Halito, hello and good morning. It's my honor and privilege to be here today to get to sit with this really distinguished panel. It was interesting to me as I was thinking about the 70th anniversary and being able to celebrate. I realized that almost to the day, 23 years ago, I started with Indian Health Service at a little clinic in Wewoka, Oklahoma, serving primarily the Seminole Nation. And I was a newly minted licensed clinical social worker that really didn't know anything. And at this little clinic, I got to really learn and celebrate successes with the community. I think my youngest patient was 3 and my oldest was probably 90. And just what we get to do within Indian Health Service as we serve these communities is really an honor to be able to stand along with communities and celebrate successes and stand alongside folks, you know, when they're maybe having their worst day. So thank you so much for allowing me to be here and facilitate this panel. So the panel that we're bringing on is talking about mental health and really talking about resilience and serving communities kind of across generations. And we have some really great folks here to talk about this with us today. With us, we have Dr. Charles Grimm, Secretary of Health, Chickasaw Nation, and former IHS Director. We also have Esther Lucero, President and Chief Executive Officer of the Seattle Indian Health Board. So first, by way of introduction, I'd like to ask, starting with Dr. Grimm. So of course, I followed your career over time, and I know you've championed many priorities across your tenure, including advancing behavioral health. I'd love for you to share kind of more about that journey in your work.
I would love to do that. I worked for Indian Health Service for 26 years, and this summer I'll be my 43rd year in working in Indian Health, and never realized it would be my full life's career, but that's where I found myself drawn to over the years. I was the Oklahoma City area director whenever I was asked to become the director of Indian Health Service. And it was, an area director is a big role, but then a jump to director, you know, of the agency presidentially appointed positions. George Bush was the first MBA president. And when I got there, they wanted to see my first 100-day plan. What are you going to do in your first 100 days? Those are all very, short-term things you could try to accomplish. And then our communications department began asking me almost my first week there, what are going to be your priorities? What are going to be your priorities as director of Indian Health Service? And I'd been in the agency, I think, 19 years at that point, so I'd grown up in it. But I never thought about setting priorities for the nation at that point. And of course, we followed whatever presidential priorities there were, whatever secretarial priorities they were, but the Indian Health Service had begun setting priorities themselves too, within the agency for our hospitals and clinics. And I told them I wasn't ready to set any priorities just yet, and they would continue to ask me every week about what, my priorities were, and I think it was probably a couple of months into my tenure before I called them together and called 50 or 60 of our senior leadership together. What I had looked at during that time was that at that time we had 13 priorities. That was a lot of priorities. They were all important. But I was reflecting on some of the things that people said today. Early on we dealt with infectious diseases. Those times had kind of slowed down due to prevention efforts and vaccines and things like that. And we found ourselves in a time of chronic disease. We knew for years, I served during a time when tribal consultation was becoming more and more formalized. It had started with executive orders, and President Bush issued one as well about that. And so we were doing tribal consultation on budget formulation, and I know that there was one of those meetings held this week in D.C. And behavioral health issues always, were a top priority. So when I called our staff together, I let them know that I was going to, I didn't say it like this, but do away with all 13 of those priorities. I just said, those are all important things and we're still going to work on, but I want us to focus on 3 things really heavily. That was behavioral health, alcohol, substance abuse, mental health concerns, because those had been big issues with tribes for years. But also that behavioral health term took in the behaviors that we as people were exhibiting and causing chronic diseases, because we had gone from infectious diseases to chronic diseases now, trying to kill our people. Chronic care management was another one of those. I found out we did not have a consistent chronic care model across our system. We were dealing with it in various ways. I put together a blue ribbon panel and asked them to study the various chronic care models out there and see what we might adopt as a system. They did that. We looked at that model, and then we made a partnership with the Institute for Healthcare Improvement out of Cambridge and started taking what we ended up calling innovations for planned care. First, it was going to be a chronic care sort of initiative. People came to me and said, everybody likes what we're doing with this. Can we broaden it to, from pediatrics to geriatrics and everywhere in between? And so we did that. And that model carried on for a long time, teaching our staff how to do rapid cycle improvements and worry about access to care. When is the third next available appointment? And we began looking at things like that. And then the third initiative, behavioral health, chronic care management, which evolved into innovations in planned care, was health promotion and disease prevention. A lot of the diseases that were affecting us could be helped or be lessened if we focused on that more. And that's usually one of the things that drops to the wayside first whenever money gets tight. You focus on the people that are coming in your door that need direct care, the medications they need, all those things take money. And so I refocused our efforts around that. And we kind of began as an agency like that. And it was fun to see things going on across all the regions, the things that people would do to get, the communities out, exercising and having events like that. We signed an agreement with the Nike organization during that time. First time they'd ever signed anything with the federal government, and they worked with our podiatrists to develop a shoe that was better fitting, for Indian people. And then they started selling them to our diabetes programs at a much lower cost than you could get them in the store. A gentleman named Leo Nolan introduced me to Sam McCracken, who worked at Nike, an Indian gentleman, I believe, from Fort Peck Reservation. I hope I'm right. But he had a real strong interest in doing that and bringing that to our Indian people. And so those three initiatives became things that I talked about in all my speeches, that I testified before Congress about. And I felt like, that era of trying to move behavioral health issues, mental health and substance abuse forward in that way, was taking it from the I'll call it the margins of healthcare. They're an important part of it, but what was focused on most was kind of what happened in the clinics. And at that time, back when I was there, alcohol and substance abuse programs were primarily run by tribes, 97% of them at that time. And 80% of mental health funding went to tribes already in self-governance contracts or compacts. And you see today still mental health and substance abuse become top priorities, in budget formulation. The funding during the time that I was there was incremental. We got 2 big doses of money for methamphetamine. Congress put in $14 million specifically to target methamphetamine prevention and treatment. And then early on, Senator Ted Stevens, very powerful senator from Alaska, was successful at getting some money put in around alcohol and substance abuse for Alaska. When we found out he was doing that, we knew there was great need there, but we said there's great need in the lower 48 too, and let's try to add a little bit more, so that we can distribute some to the lower 48. And so we ended up getting a $30 million increase, 15 to Alaska, 15 that we put, in distributions to the lower 48. And that particular issue pointed out some policy items at that time. Alaska did have great needs, and they were very distributed, a lot of transportation issues, a lot of high alcohol and substance abuse in their communities, and they absolutely needed that. And so that regional change in the way we hand out money, that was, an area that, very quickly started having us look at the formulas that we do and modifying them. Some of the formulas that we modified after that were 4-part formulas or 5-part formulas that recognize differences among the regions in the country, and that might be 25% of a distribution. So, during that time, I really spent a lot of my time testifying on things like that. I remember one time we had a hearing. Senator Dorgan was the chair of the Senate Indian Affairs Committee at that time. He asked me if I would come to his state and do a field hearing on youth suicide. And I said, yeah, I would do that. So I took some of my team out there. The news covered it. There wasn't social media at that time, so it was harder to get the word out about things, but the TV covered it, and we had families that came that had lost people to suicide. It was a heart-wrenching, set of testimonies and things like that, and then the press interviewed myself and Senator Dorgan afterwards. There were clusters of suicides with our youth, that were around during that time. We had a terrible school shooting at Red Lake, Minnesota, during the tenure that I had up there, and we spent a lot of time up there. So I felt like it was the right thing to do to bring it in as a national priority, for us at that time, and also hopefully elevate the funding. We did get some additional funding, but I still wanted to point out that by 2008, and I left in late 2007, but I had worked on the 2008 budget, so we had $63.5 million for mental health at that time. I just took a simple calculator that calculates inflation. That would be $102 million in dollars today, and we got $131 in that budget for FY26. So, we're we're better than what inflation would be, but we still need more money in that account. Our alcohol and substance abuse monies back then when I left were $159.5 million. The escalation for inflation would make that worth $256 million today, and our FY26 allocation is $267 million. So we really, really still need to focus on those line items as well as others. You know, we're keeping up with inflation, and we're a little bit ahead of inflation, but there's still huge, huge needs out there. That's how I start getting interested in prioritizing behavioral health, alcohol, substance abuse, and mental health issues.
I so appreciate hearing that history because of the work that you were doing. I was able out in the clinic to get out of those four walls and go out with the community health representatives, right, and go out with the public health nurses. And so that policy, really translates to what we were able, to do at the community level. So thank you for sharing that history. And Ms. Lucero, I would love to hear just a little bit about your journey in this work as well.
Yeah, so good morning, everybody. First, I'd like to apologize for being so discombobulated. Our Executive Vice President, Abigail Echohawk, wasn't able to be here today, and so she asked me to kind of fill in, so I'm going to do my best to be a close second, I guess. I guess we now know who works for whom. This is actually, public health and community health is actually my second career. I was in the corporate world for a long time and decided to go back to school. So I cut my teeth in public health and community health at the Native American AIDS Project, as an HIV case manager. I was trying to decide whether I was going to go to medical school or law school, and I didn't do either, so that's kind of how that happened. I had the privilege of working with folks like Marty Wakazu at the Native American Health Center in Oakland. And if I think about mental health, he tells this beautiful story, and I don't think he'd be upset that I tell it now, where he said, I remember the first time I asked for mental health funding. He said, I went to, the city council and I said, you're about to lose your only native mental health program, right? And it was no Gallo. And then he submits like an invoice for a chainsaw. And so Noel's like knocking on his door and he's like, Marty, why do you need a chainsaw? And he said, to cut the wood for the sweat lodge, right? That's the mental health program. And I just remember like being introduced to community health and mental health and, just native health in that way from him. And I think it set that foundation. I also had the privilege of working with folks like Dr. Terry Maresca. I shadowed her for 3 summers when I was in pre-med and spent time on the Funky Farm and learned about herbal medicines and the ways that you interact with your community to be able to understand what those traditional ways of healing are. And so I think that set the foundation. And so now I'm celebrating my 10th year as the president and CEO of Seattle Indian Health Board, and really just proud of the work and proud of the team. Also, why are there so many former IHS directors in this room? Why is that? I love seeing it, though. So that's pretty much the journey.
Yeah, thank you for that. And I'm so glad that we have so many people here that are able to celebrate, right, and share this history. So we have a couple of prepared questions that I'd like to share. So first, based on your experience, how does the Indian health system support resilience and healing across generations? And what approaches have been most meaningful for communities in your experience?
So when I think about resilience, I think about tribal elders, tribal leaders, community members that have taken our tribes through all these different federal policy eras, some that were more friendly to Indian tribes and some that were less friendly. A lot of tribes moved and experienced that loss during moves and the intergenerational traumas that all the things we've heard about in the press, boarding schools and relocations and termination of tribes and things like that. And when I see what tribes are still doing today, that is a strong example of resilience. I think it's built into our genes. Whenever I was the director of IHS and had an opportunity to travel around the country, and that was one of the most rewarding things about being the director of Indian Health Service, I would say, is to get to travel around and visit with patients and community members and tribal leaders and things like that. And I used to always say, I wish I could allow my staff to see and experience the things that I did during those times. Social media makes that a lot easier. The weekly newsletters, that are sent out by IHS now, electronic newsletters, those things let people see and experience some of those things. But again, talking about focus on, alcohol and substance abuse and behavioral health, I traveled around to different regions when I would. If there was a youth regional treatment center there, I would try to stop in and visit with the leadership, and sometimes, and usually, not sometimes, almost always, they would have a little talking circle, with the kids that were there, and I would get to experience that. And sometimes I would be with more senior leaders too from the department coming. I remember one time going to the youth regional treatment program, and one of the kids said something about, and I still remember it to this day, this is the first place that when I came in, they asked me where I was from and what I thought about my tribe before they asked me what was wrong with me. And those programs are run by our community, leadership. So that made an impact on me. There was another time when I was with the Deputy Secretary of HHS, and we were at a program, and we sat, and the kids went around the whole circle and told us why they were there, their experiences. And I remember, I would say it was all I could do to not cry at some of the things they had experienced, to get there in their young lives. But I did cry a little. I tried to I tried to hide it, but it wasn't very well hidden. And so, seeing them there and healing and thanking us, for the funding that we put into those programs, because they said, if it wasn't for this, I would probably be dead already, And I feel like I really have a chance now to, live a full life and go back and be a part of my community. I mentioned, that there were, and I know we still have them today, but there were starting to be a lot more clusters of youth suicides during my tenure. One of the things that we did was establish an IHS National Suicide Prevention Initiative at that time. And we developed area-level suicide intervention and initiative programs so that if anything were to happen, or whenever a single suicide might occur, we would get the community together and we would work with them. We'd try to work with the youth at that time, to find out what their concerns were and try to stop those things from occurring. And while I think we were successful at some of those interventions, it was a Band-Aid, if you will, to try to stop a bigger problem that existed, with youth. And I think our youth today have to, the 24/7 social media and things like that, they can't get away from the noise sometimes. And sometimes that noise is not good for them, bullying and things like that. So I think we still, have a lot of work to do in that mental health arena. But I think the things that you see, that we do, that the communities do, are about building resilience in them. And, you could probably take all these topics that we're looking at today and talk about a portion of them that build resilience in our communities. And I'm just, thankful that we have the opportunity to help play a role in that in our communities. When I left Indian Health Service after 26 years, I have now worked at 2 tribes. I worked for the Cherokee Nation initially when I left IHS, and I'm a citizen of the Cherokee Nation. And I got to see what they were doing in this arena and what they, I talked about the funding a little bit earlier. It's better, but it's still not, sufficient. And I guess our entire budget is that way. I hadn't heard what the final number is on the national budget formulation meeting this year. And I have some excitement about potentially one day getting full funding, getting mandatory funding, for our full needs. I think we're closer than we've ever been to that. But whenever I went to work for the Cherokee Nation, I saw what they were doing, expanding school-based prevention programs and, language programs, recreational programs for our youth that are culturally based. And they put a lot of time and effort into that. At the Chickasaw Nation, where I'm at right now, one of the things that our tribal leader, Governor Bill Anatubby, did a number of years back when he reorganized the tribal government, and he created it in a mode where I'm a secretary, a cabinet secretary. He created a cabinet secretary it's called for family services, and they have a host of family service programs, from youth to, adulthood. But essentially what that was the mental health and the alcohol and substance abuse type programs, kind of coupled in with some other sorts of programs. But he elevated it to a cabinet secretary position. It elevated its importance in the tribe itself, and then started putting more money into it. And the Chickasaw Nation has put a lot of money into, that particular program. And we like to call it mental wellness in our community. And since that program has been developed, since it was elevated to cabinet secretary, I say we do, but the secretary of that department and his staff put together a state of mental wellness in the Chickasaw Nation, so that we can look at the statistics on the various aspects, in those programs, and make ourselves and the community aware of it. And so, we talk about systems and programs and processes, and those are all very, very important to operate, anything really, but a health system or a program. But it's really about the people. And I think somebody else said something similar to that earlier. Resilience is about our people. And one of the things I think is really neat is when mom and dad's working and a grandparent brings their grandchild in to a visit and sits there in the visit and learns about what's going on. And the grandchild gets to interact with the grandparent, as well in that setting. So anytime I see or hear anything about that, I think resilience too. So.
Yeah, I appreciate that. I had learned last year of a tribe that had wanted to increase their generational connections. And so when they did any kind of activity, like they made some ribbon skirts, so you had to bring someone that was from another generation to participate with you. And I love that, like grandparents with grandchildren. So Ms. Lucera, I'd like to ask you the same question.
Sure. I think, as an urban Indian health program, it's really important to note that, we are an extension of tribal sovereignty through the healthcare delivery system. It's our honor and privilege to take care of tribal members from many different tribes when they come into the cities. We know that the majority of American Indians, Alaska Natives live in urban areas now. And so what that does is it creates an environment where it can be challenging to serve so many different tribal nations, given the fact that we have so many distinct cultural epistemologies. So as an urban program, we set out to just be unapologetically who we are. Now, the mission for the Indian Health Service System was what allowed us to create that foundation. We created our Indigenous Knowledge-Informed Systems of Care through that foundation. Because traditional Indian medicine is mentioned in the IHS mission, it gave us the legal platform we needed to be able to move through the world in an unapologetically Indigenous way. Now, I'm going to tell you what I mean. When COVID happened, we decided that we were going to implement our cultural framework. It took us 2 years to build our cultural framework to make sure that we were respectful, of many different tribal cultures. And we started just doing something simple, like smudging twice a day. Now, I'll tell you, within our organization, oh my goodness, it was such a big deal. All of a sudden, everybody was allergic. right? We had all these lawsuits threatened, and so we actually had to work with our attorneys to determine whether or not we had to stop smudging. And the reason we didn't have to stop smudging is because of the IHS mission statement, and because as an IHS contracted entity, we would have to change our emissions so significantly to stop that action that it gave us a legal platform to move forward. Once we had that legal platform to move forward, we moved forward in an unapologetic way. Meaning, not only did we smudge twice a day, but we did everything that occurs in our organization is centered on traditional Indian medicine. That is a model that works, because we know that strengthening cultural identities is key to youth suicide prevention. It's key to youth healing and wellness, right? Is to create an environment where sometimes, due to the policy that you were speaking of just now, our cultural identities have become dismantled a bit. And it was intentionally, right, dismantled. So in order to heal from that, we need to create an environment where people can culturally reconnect, strengthen their cultural practices, to engage within multi-generational systems. I have an elder who said, when you get 4 generations in a room, healing happens. So, yeah, I saw the sign, so I'll stop.
I love that, unapologetically indigenous, coming from that framework. I wanted to shift just a little bit and talk specifically about youth and families, and we've touched on this a little bit, but I'd like to ask about community-based practices that have helped strengthen the mental well-being, particularly for youth and families.
You know, I'm trying to think, you know, we often will have initiatives that focus on a particular age group. And I was trying to think, I think almost all of our youth initiatives that I can recall in my mind, you know, we focused on the family as a whole, too. We always want parents to be engaged and involved. One of the things that I've learned over time, you know, whenever I got my training, and you learn the theory behind all the things you do, that community-based programs only work when they're built by the communities, really, you know. I mean, somebody can come in from the outside and kind of pull you together and start talking about a community-based program, and that person probably already has an idea about, you know, kind of how they would like to see it work, but as long as they don't dictate that, as long as they let the community really develop it and really own it. And Dr. Rubidoux, I don't see her anymore. There she is back there. Hi, Dr. Rubidoux. I didn't get to say hi before the meeting. You know, she mentioned the SDPI and why it was so successful. You know, I have to agree with her that that is one of the most successful programs, and there are components of that, you know, bring the family together to do things. And I think, you know, when mom and dad might have a problem with diabetes, and maybe a child would be destined to, you know, experience potentially that same disease, and they do things together and work on it, it's just way more successful than when we send a youth, you know, to a particular program, even though we do that a lot. And those programs are successful, but I like the model of youth and family working together. One of the things that I was proud to support whenever I was director was the behavioral health aid program that started up in Alaska. And Alaska has started a lot of things like that, and a lot of it is due to the isolation and the small populations in the villages, and so needing a community member who is interested and willing to take on that role, you know. Whether it's a community health aide, whether it's a behavioral health aide. They had dental health aide therapists, too, that, you know, came about in my time. But, you know, the behavioral health aide therapists had, I think all those folks that are a one-person shop in those communities have difficult jobs. Don't get me wrong. But, you know, the behavioral health aide really, you know, taking on some of the issues in the communities, things like that, and really getting to know the needs of the community. I used to kind of joke around when we would visit some of the communities that the behavioral health aide knew more about things going on there than any of us that were in the entourage that were visiting, even though some of them were from Alaska area, you know, and things like that. And so I think that is one where, you know, you're dealing with families. You know, they deal with individuals, but they tend to deal with families too. At Chickasaw Nation right now, one of the things that we're doing that I think is it's a really impactful program, and it's really dealing with youth obesity, you know, childhood and youth obesity. But the way we're tackling it is with the family. It's not just working with the child. The family has to commit to work, you know, with the child in the care, and it usually helps the family too. But we have a pediatrician, we have a medical family therapist, so mental health is involved. We have a nutritionist, and we have a physical therapist. So it's a team of those 4 people, and they can call others in if they need to. And we're seeing remarkable results with what we're doing, because it's not always about eating, you know, and it's recognition that sometimes there are mental wellness issues that are involved in those, and sometimes it's a family dynamic too. And so it really is an incredible program, and we're starting to scale it up a little bit. We did it early on as sort of a pilot, if you will, and we've been collecting data on it, and it's really been successful, and we're going to be spreading that. So I would say, you know, what I saw in youth and family, both at my time in Cherokee, Chickasaw, and in Indian Health, whenever you get the family together, it just seems to be much more successful. And I think it goes back to building that resilience that we talked about in the first question, you know, whenever you have that nuclear dynamic family working together.
I think I'll just dip into the fact that we have 3 years' worth of data. With individuals who have access to traditional Indian medicine, we're seeing a 76% reduction in suicidal ideation for those folks who are at high risk for suicide. We saw a 32% reduction in suicidal ideation for those that are low risk. Let me see here. We saw 24% reduction in depression. Similar results in anxiety. We saw a 46% reduction in uses of substances just by having access to traditional Indian medicine. Yeah, those results are incredible. And I think that if we're thinking about this administration, if you want to see a reduction in costs in hospital systems, you have to get upstream and invest in cultural interventions and prevention and early intervention.
Yes. So you have set up the next question perfectly. How do culturally grounded approaches contribute to prevention and early support of behavioral health?
She's very good and very succinct. I feel like I need to get more succinct with my answers, but that's not the way I am. You know, one of the things that I have come to believe and learn over time too is that cultural beliefs, traditional medicine, traditional healing practices are a key to that. I got to experience some of those when I was area director or IHS director. And one of the things we were pushing for, and I really am glad to see it's almost there, is, you know, traditional medicine and practice getting some sort of reimbursement, you know, for our health systems and becoming more mainstream. You know, that time that I spent as IHS director, when I traveled around, I would often be invited to, be involved with some traditional practices, and I always said yes if it was appropriate, and I always felt better, you know, mentally as well as physically a lot of the times whenever I left that location. And so we tried, as an organization to support any of that going on. And I remember, my time there, that we would talk to tribes as we were developing new facilities for them, and ask if they wanted to build in a place for, you know, their traditional healers or their traditional practices. We tried to get the federal staff at our locations, you know, to engage the tribe and see if they wanted to do that. You know, there's some tribes that don't want their healers, you know, inside the four walls of our buildings. They prefer to do it in other locations, but to really sensitize our you know, physicians and our nurses and people like that to accept that. If, you know, if there were anyone in our staff that didn't, you know, we encourage the leadership in those locations to help them learn more about it and to accept what was going on in those communities. Because sometimes if you come from the outside, you're not sure what that is and what it means and how helpful it is. But I mean, there is no doubt in my mind anymore that all of the cultural practices that the various tribes have are the most powerful form of prevention and treatment that we really have in our communities. You know, I could list some experiences at Cherokee and at Chickasaw where, you know, they're just making our culture more available and more easy to. This is an easy way to get succinct. That's. I never saw the time lady before. Thank you. So I would just say that, you know, as I've begun working for tribes, that I see more and more how they're putting their culture out there for their youth and for the families and making it more easily accessible. And that also means, you know, healing and traditional medicine and things like that. So I think it's great. I think it's happening all over the country. I love to hear the stories that you're telling about the successes too. So we need to just keep doing more of it.
I'm just going to be super quick with this. So we created Family Saturdays, which is centered on youth and families. It's all around cultural activities. So you might have drum and dance class. You can do some traditional medicine activities, all around for the kids. And what we saw from that is we have a 0% no-show rate on our dental appointments on that day for youth. We've increased our vaccinations. We have a 0% no-show rate for our pediatrician on that day. And that is what it takes. But I think about folks like Dan Dickerson out in LA. I'm looking at Dr. Rose Riaki, you know, doing that work around how drum circle is just as effective as AA and sobriety. I mean, this is not magic. This is not magic. We know this works. And now we have the data to prove it works. And now we have mechanism to bill for it. So let's get going.
Yeah, I love that. I had, there's a program in Baltimore, and they said they come for the drum, but they stay for the treatment. Mm-hmm. And I think that is kind of where it's at, right? Mm-hmm. So we've got just a couple of minutes. I just wanted to give some final time for remarks.
I think in the final time, you know, our residential treatment program is going to be opening up on July 11th. Anybody who wants to come for the grand opening, please come. The reason I'm sharing that is because that program is centered on traditional Indian medicine as well. And we have the lowest recidivism rates in the state, or the best recidivism rates in the state. And it's only because of our traditional medicine practices. And so I just want folks to move through the world in that unapologetically indigenous way. You have to. We have a legal platform for it. We can transition these Western mechanisms to work for us, and then we will see healing happen. So I just thank you for all of the work that you do every day, and I'm glad to be here.
I would just say that one of the biggest lessons that I've learned throughout my whole career in Indian health is that collaboration has to be built on respect and trust and listening. And sometimes that gets a little messy. Dr. Rubidoux mentioned trying to create a formula, you know, for diabetes funding. But Indian country always finds a way to do it. And I think it's because we remember we're all serving the same people, our families, and the same future generations. And I just feel blessed that I've gotten to have a career in Indian health. So thank you all.
Thank you so much. Let's have a round of applause for our panelists.
All right, at this time, if you would mind rising, everyone around the room, if you would just stand up with me. Stand up all around the room, take a quick stretch. We're gonna stretch it out for a second, but I want you to stretch with style. There you go, move it around for a second. There you go at the table. Mr. Fulton has a quick message for us.
Keep standing, enjoy your time. I did just want to make a quick highlight for you. Secretary is a very busy man and has been drugged to the White House this afternoon, so we're going to be making some pivots along the way with our scheduling. So we'll have our same next panel, followed by a quick lunch break from 11:50 to 12:20. We'll do a quick set of IHS Leadership Awards between 12:25 and 11:15. And then the Secretary will be here to give his remarks at 1:30. So that's a little bit of a 3-hour deviation from where we thought we were going to be able to have him today, but we appreciate him finding time to make for us. He did not want to leave you behind despite schedule changes, so they were able to squeeze us in. We're very excited for that. So please continue to mix and mingle as we bring on the next panel, but I did want to highlight those for you. Appreciate it.
Produced by the U.S. Department of Health and Human Services.